systemic mechanisms, the lower HbA1c, lower blood pressure, reduce volume and direct effect, and cause weight loss. So that's, in summary, what, as you know, these agents are doing. Now, for those scientists that want to know how it works, this is how they do so. So in the early part of the proximal tubule, the glucose that's brought to the kidneys from the blood flow, 90% of it is reabsorbed, and they do so by stimulating the SGLT2 protein, and also on the other side of the cell, the GLUT2 transporter takes the glucose through. So you get the sodium glucose transporter 2 working in collaboration with glucose transporter 2 as the patient becomes hyperglycemic. And then in the distal tubule, you have only about 10% of the glucose reabsorbed, but this time it's the glucose transporter 1 and glucose transporter 1 which are responsible for transferring the glucose from the bloodstream through the cell to the other side of the kidney cell, to the other side into the bloodstream. So from the proximal tubule back into the cell and then back again into the plasma, so that virtually all the glucose that goes to the kidney is reabsorbed. This just shows how the actual suppressor for the pro-inflammatory gene that causes the production of pro-inflammatory chemicals, which then cause endothelial function, this gene production is suppressed in normal glycemia. And as soon as glycemia does happen, then that causes the stimulation of the pro-inflammatory gene expression, and then you get more pro-inflammatory cytokines and reactivation of oxygen, reactive oxygen species that will lead to a huge metabolic injury to the endothelium and also to the glomerulus. So in normal glycemia, we seem to suppress the production of those pro-inflammatory genes, which are then upregulated when there is persistent hyperglycemia. We were talking about the sodium glucose 2, the transporter 2 and tubuloglomerular feedback earlier, and if you can see here, if I could work this, there we go. So tissue growth factor is bad for the glomerulus, and you can see that in normal glycemia. I'm sorry, this is not working properly. The actual sodium glucose reabsorption happens here through this protein, and then you get less sodium coming to the macular densa, and that tends to restore restore the arterial tone here. And you remember that the production of normal glomerular filtration is the gradient difference, is the pressure gradient difference between the afferent and the efferent arterial. What happened to that pointer? We haven't got a pointer. Okay. And then if you have hyperfiltration in the early stages of diabetic nephropathy, you get increased sodium glucose reabsorption and then a decrease of sodium delivery to the macular densa, and that causes vasodilatation here. So the pressure gradient between that and the efferent arteriole increases, and that causes elevated glomerular filtration, and that's the hyperfiltration stage. But because if you then block this reabsorption, so you then get normalization or increased sodium delivery, that restores the pressure gradients between these two, and therefore you normalize glomerular filtration rate. So in the beginning, these agents actually are renoprotective by blocking hyperfiltration of the glomerulus. So this looks complicated, but in fact it's quite simple. Everybody knows what the ACE inhibitors and angiotensin II receptor antagonists do. So they reduce the efferent arterial tone here, and therefore restore the pressure gradient between the two and protect the glomerulus from hyperfiltration. So that's how these drugs work. And if you then look at that, that will reduce proteinuria and then will cause renal protection. And what these agents are doing is similarly, they are then increasing the tone here, and in a state of hyperfiltration, that then causes you get initial EGFR reduction, but that then is followed by reduction of albuminuria and therefore renal protection. So it looks like the SGLT2 inhibitors are working in a similar fashion to the angiotensin II receptor antagonists. So, you remember that the FDA put out a recommendation that for any new anti-diabetic agent, there's got to be, the trials must be done so as to show that there was no increased risk, cardiovascular risk to the patients. And so a lot of these new agents have also, the companies have put out some very interesting studies, and this is a list, a complete list of what's happening. So all the incretin products, the companies have come up with these studies so to look at cardiovascular effects of the glucose control in our patients. So some of these have reported, others are reporting in the next 2 to 4 years. So there's plenty of studies to come out. So let's just review one that has been reported and has been shown to have an impact on cardiovascular events. And this is the empagliflozin that's been published in the New England Journal in 1915. So they screened 11,000 patients and randomized 7,000. Placebo versus empagliflozin, 10 milligrams, and increased dose of 25 milligrams. And here is the three-point primary endpoint of the major adverse cardiovascular events, i.e. cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. And as you can see in black is the patients who had empagliflozin, and in gray patients who had placebo. And you can see over time, there was a significant difference in the three-point major adverse cardiovascular events. There was benefit in those patients who were taking empagliflozin over time. And this is a graph again showing the benefit to reduction of cardiovascular deaths in those patients that had empagliflozin over a 4-year period. A significant reduction in number of cardiovascular deaths. Hospitalization for heart failure, again showing benefit with empagliflozin over placebo. And this is a renal outcome, similarly significant reduction in the incident and worsening of nephropathy over time in red, and in gray, these are patients who, I beg your pardon, who had placebo rather than empagliflozin. The others have not completed the studies yet, so there's one called DECLARE, which dapagliflozin is being used for that group of patients in the intervention arm. One called CANVAS for canagliflozin, and the other one called VERTIS-CVO using it to gloflozin over time. I can't pronounce that one. Just on renal outcomes for the dapagliflozin, and this is a randomized, double-blind, placebo-controlled study randomizing to dapagliflozin 5 milligrams and increasing to 10 milligrams versus placebo. So 252 type 2 diabetics with moderate to mild to moderate renal impairment, and primary outcome was HbA1c at 24 weeks, and secondary outcomes change from baseline of eGFR and creatinine clearance over 52 weeks. And this is what they found so far. So if we look at the early mean decrease in eGFR and creatinine clearance followed by longer-term stability, there was a higher incidence of urinary albumin creatinine ratio of 1800 milligrams per grams over 104 weeks. With placebo, if you compared it to dapagliflozin at 5 milligrams and 10 milligram difference. So there was a significant difference in proteinuria reduction. So to me, it seems actually the SGLT2 inhibitors have now justifiably found themselves on the right position in this algorithm as shown from various guidelines, ADA and the AASD. And it's the same for the UK with the NICE guidelines. We already now have been encouraged to take this group of drugs for second-line therapy in addition to metformin. And in some patients who are intolerant to metformin, it does make sense to choose any of these drugs here as first line. And of course, for 3 drug combinations, then it depends on your choice and the cost of which one you will choose for your patients. Now, just to sum up in the next couple of slides, and here is now the list of adverse side effects from these drugs. This list is for the dapagliflozin, and you can see genital mycotic infections, slightly higher than placebo, nasopharyngitis, and urinary tract infections, and so on and so on. So there is slightly increase in the adverse effects from the drugs, around about 22% of the patients that took the drugs. Now, the other one that's been reported more recently is the prevalence or incidence of diabetic ketoacidosis. We have to be very careful how we use these drugs in those patients that have got very poor control of diabetes and are non-compliant with diet, i.e. any patients who are at risk of developing diabetic ketoacidosis. It's possibly that it'll be safer not to use the agents in those patients. Again, this is just further studies that have come out, but fortunately it shows to me that the actual incidence of diabetic ketoacidosis is not very high. And as you can see here, Erondo et al. Published the experience of 7,596 patients, and only 12 of those did develop diabetic ketoacidosis. And the same thing with the other one published by Peters et al., showing 13 episodes in 9 individuals with clinical practice across USA. 7 of those patients had type 1 diabetic, type 1 diabetes. I mean, some clinicians have been using these agents in type 1 diabetes. So it looks like, in general, the feeling is that DKA from these agents is quite rare, and you can actually avoid it if you choose your patients, or at least if you don't give it to those patients at risk of diabetic ketoacidosis. So to conclude my talk, then please can I advocate these take-home messages. Firstly, is that SGLT2 inhibitors are promising in reduction of renal and cardiovascular events. The adverse side effects are not actually as worrying as I thought they might be, and in fact they are treatable, and DKA particularly is preventable if we choose the right patients. But in general, if somebody is got very poor glycemic control, or you're worried that they are not going to comply with diet, then it's best to avoid the SGLT2 inhibitors and go for the other oral hypoglycemics. Thank you for your attention.
Thank you, Professor Mike, for this important presentation about inhibitor, SGLT2 inhibitors and outcomes of cardiovascular disease. Is there any question for Professor Mike? And okay. Yes. You want to see?
I'm sorry, do you mind using the microphone?
Me?
What is the type if the most suitable for treatment of patient of TAPS meals?
I'm sorry, I don't get that. The site.
Exercise.
Oh, exercise. What's the effect of exercise in
Use micro, please. Use micro. We don't.
Apologies, I just didn't get that.
I think it's for
Please,
Professor
our
Ma.
doctor بيسأل عن الtype of exercise. We make for patient 2 or 3 times in weeks. For type 2 diabetes, exercise.
Okay, what sort of exercise should
Type. Type.
Type.
Yes.
Okay. Oh, yeah. Okay, yeah. So, I mean, obviously, lifestyle modification is important for the treatment of type 2 diabetes. And the first thing you'll encourage patients to do is to look at the diet and look at exercise. So, type of exercise really depends on where you come from. In some areas, they got gymnastics. Some areas they don't have, or they can't afford gymnastics, so you rely on walking or cycling, swimming. So any type of exercise is important in a controlled diabetes. Remember that you don't particularly have to do vigorous exercises. Some gentle exercise increases response to insulin, so improves insulin sensitivity. So in this group of drugs, you still have to say to the patient, they got to address lifestyle modification. Sorry, yeah.
Okay, thank you very much. Why SGLT2 inhibitor couldn't be used in type 1 diabetes? It decreases the glucose blood level, so we can decrease the insulin dose. And it is, as you said, cardiovascular protection and many benefits. Because trials have not been done at a long scale, at a big scale.
Yes, I think it's logical to
yes, it's logical
to try SGLT2s in type 1 diabetes.
Yes.
But at the moment, nobody's actually demonstrated that that's of any benefit. If anything, there's a risk for ketoacidosis.
Yes, they tried it. And ketoacidosis incidence increased?
Exactly.
Yes.
In theory, but I suppose the actual, the glucose levels is extremely high in type 1 compared to type 2. So you might as well just use insulin because you're not going to treat them without insulin.
Yes.
Yeah. So I think
I think it's
in the presence of insulin, the
adaptive therapy with insulin.
actual renal excretion of glucose is not significant.
Yes,
You can only excrete so much. Yeah.
thank you.
So in type 1, the benefit is very little. You might as well just use insulin.
I think that if I give it together with insulin, I can decrease the insulin dose. Can be used.
Yeah, sure.
Type 1 diabetes because there are a lot of papers which say that there is an increased incidence of acetone body formation and ketoacidosis. And
Yes.
all the published papers say that we are not allowed to do this. Okay?
Sure.
So this debate should be closed.
Yeah. No, it's true. I mean, there's no benefit and it's risk for ketoacidosis. True.
I want to thank you very much. I want to ask Professor Nam for, as you know, it's important to make diagnosis early during pregnancy. And what do you think about to add to a risk factor HbA1c more than 5.6? Is not a risk factor? For patient with pregnancy to have some risk factor and to have HbA1c more 5.9, it's a risk, is a risk factor.
Well, actually using HbA1c, you'll be able to isolate B1 less. It's not working. This one on, but it's not working. Okay. Using HbA1c, you probably be able to identify B1. This is pre-diabetes, okay? But GDM, there will be a normal level. So this is not detective enough, sensitive enough to detect GDMs.
Another question, please.
It's better to avoid SGLT2 LT2 in insulin dependent. It is a relative contraindication. Suppose, for example, I give example, if my patient in every 3 months or 6 months have a trace, whom is insulin dependent, have a trace acetone. This to be avoided? To avoid using SGLT2?
For which group of patients, sorry?
For a patient insulin dependent and have constant trace acetone. Ketonuria.
Yeah. I think the risk is so high that we should not be using these at all in type 1. I mean, the previous colleague,
Yeah.
I don't think we should be using SGLT2
In type 1.
inhibitors in type 1.
Thank you.
In experimental setting, that's a different story. But in clinical setting, I think we should stop using them because there's very high risk of diabetic ketoacidosis.
Thanks.
The last question.
Last one, please.
Thank you very much. And I would like, first of all, I'm Engineer Khaled, I'm not a doctor, I'm having a medical company. Dr. Nam, please, when I saw the figures of the Egyptian diabetic patient, it is really a huge number, and the Middle East also. So I want your advice, as you are a professor from Korea. Korea now is a very advanced country, to the Egyptian people, especially, I'm sorry to say, when I went outside, I found even the doctors here, the Egyptian doctors, are eating so much and adding a lot of sugar to tea and coffee. Thank you very much.
it was a comment. I think we closed the session, and thank you Professor Mike, Professor Nan, and for my colleague, Professor Shihnaz. Thank you very much.